Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Just go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need. Are there any other situations other than dentigerous cysts where you would put a jugular sample into a defect or create a clot for improved healing? Amelia Jane asked that question. Amelia Jane, that is dependent upon the volume and also where it is. So if you do an extraction in the mandible, especially mandibular canine tooth, there may not be enough blood in that thick cortical bone when you're ready to close to be able to close. Sometimes you want to go back and you want to scrape that cortical bone, see if you can get a blood clot that's going to come up to the level of the marginal bone that's left. If that's not the case, then indeed, in answering your question, you could use a jugular sample and just fill that alveolus with blood and then suture over the top of it. So really nice question there. Morgan, most common breed, Morgan DeShell. Most common breed for dentigerous cysts is brachycephalic dogs in general. Boston Terriers, pugs are super bad. Boxers are bad, but any brachycephalic dog is up for grabs when it comes to missing first premolar in the mandible. Carol Kluka, how painful are dentigerous cysts? Would a small cyst be painful on palpation such that it might be detected on physical exam? Generally, no. They're not painful. They become painful when they break through the bone and they get into the tissue and form a fistula. Then you have bacteria coming in, inflammation coming in to the defect, to the cyst, causing inflammation and infection, then it's painful. So these go undetected many times, and it would be nice if they were painful and the patient showed signs when they first started, but that's just not the case. It doesn't happen that way. And Melinda has a question. I've touched on this a little bit. Are these cyst repairs really suitable for general practitioners? If they're beyond a volume that's manageable with a simple flap exposure and they don't involve the canine teeth, the answer is yes, you can do that. It's like extracting an unerupted tooth. If you're comfortable extracting an unerupted tooth, especially that same tooth, that first premolar in the mandible, which is generally the case if it's early and there's minimal bone involvement, even if the canine tooth has a shadow of involvement that's not too big, and too big would be maybe the same diameter, maybe a little more than the tooth itself that's unerupted, then many of you would be comfortable doing that. Otherwise, be best to refer if you're not comfortable with that. Jennifer Voles, is there a reason for why the premolars were not removed in this case, even though they have lucencies at the roots? And for those of you, let's look at that on the screen. For those of you who are listening on the podcast, then there are some increased periodontal ligament spaces around these tooth roots, which we now have to determine that are left, obviously, after the extraction. We have to determine if we are extracting those or not. And I can't recall on this particular case specifically, but those Those are, I can't recall in general what the determination was, but I know this patient had increased lucency around all of the teeth that are more involved than what we would normally see, because it's a bigger, or it's a younger patient. It's not a super old patient, as evidenced by the lucency around the tooth itself. So if comparatively, which in this case it was comparatively similar to other teeth, then we don't extract. And my guess is that this is probably, I don't know this is the case, was what I was getting to, and I got off on another thought, but I don't know if this is the case where we just took a post-op radiograph of the extraction to make sure that was okay before we went on to proceed, because we do have a fractured incisor that I know we extracted that shows up in that image, and we haven't done the other side yet, so you can see that in the image as well. So very, very likely that we left those because the other ones were similar, and there's no reason to extract those. And visibly we look at that too. So if we do a cyst removal, sometimes we can see the tooth root. If the apex is not involved, then that tooth root stays because it will form cementum. In all likelihood, it'll form bone around that tooth root, and it will fill in normally, and you won't be able to tell. There'll be a periodontal ligament space, and it'll look normal after that bone fills in where you put that bone graft or that blood clot. Kyle Johnson asked a question: if not properly dealt with, can those come back? And in other words, is if the cyst material is not removed completely, can those recur? And indeed they can, and indeed they may. I have never had one, knock on wood, that has recurred. We have had one case in a cat where they had a cyst that also had neoplasia associated with it. We just did a case when we were in Orlando or Atlanta, I can't remember, that we just got the pathology back, and it was suspect of possibly having a neoplastic component that is one of the rule outs going forward, but it wasn't definitive, so we'll monitor that case radiographically in order to determine that. So there could be possibilities where they don't work, and certainly depends on the skill and experience of the person doing the cyst removal, but those are, in our experience, almost non-existent, where you have to look back and see that there is indeed a cyst forming again. Again, the only time we've had that is with neoplastic component to it in a cat that I can recall. But that being said, you do want to follow these up radiographically. We look at them we'll look at that one with the neoplasia in 6 months. We generally look at a year, 18 months in the future to see if there's bone growth, or if there's evidence that there's not bone growth, where we expect it to be a full replacement of that void with bone when we repeat that radiograph. The last question here on cysts: do you do anything if a canine tooth only erupts halfway? And we had an example of that where you could see the crown of the tooth. There was a cyst associated with the entire periodontal ligament space. You could see an increased periodontal ligament space around the whole tooth, especially at the marginal bone level where the crown was. And so in that case, where we have a canine tooth that shows changes, obviously we're going to extract that. But if we don't have that, and we have a canine tooth that is partially erupted, and we see this patient at 18 months or less, and there's no changes, there's probably not going to be any changes. We would follow it up anyway, maybe at 2.5, 3 years of age, just to make sure. But we would not we would not recommend extracting. We would recommend monitoring, because those are nightmares, even in the hands of a specialist in some cases, to get out. We have a Vetome now and have had that for several years. We love that. That's super effective at these cases where we're using a periotome, essentially, if you're familiar with that. That's mechanical, that goes down in the periodontal ligament space and loosens that tooth up. But otherwise, they're very difficult to extract, and we definitely would not recommend that, not as a referral. That's got to be a referral if that tooth is only partially erupted. The other thing, Heather, that we can do if it's partially erupted, but the crown of the tooth is just surrounded by bone and there's no cyst there, we'll open up a surgical flap and we'll remove the bone around the crown. And then we'll suture that flap back to where it's at the new bone level, and we're able to keep that tooth. So that's another option. That's, again, a specialty level thing. We do it if we see it on referral, and I wouldn't recommend it in general practice. I would recommend monitoring that unless the owner wants to be absolutely sure that's not going to develop. You can certainly refer for that procedure, or possibly refer for that procedure if that veterinary dentist does that, and some may or may not. So a great question. I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.